If you just heard the words, you have breast cancer, then your brain has probably not stopped and it's probably working in overdrive right now. You have an idea of what chemotherapy is, and you know that surgery may be likely. But now there's hormone replacement therapy, immunotherapy, radiation, and all these other forms of treatment. And you're probably wondering, what does this all mean? And so if this is you, if I'm speaking to you, then this video is for you. Today, I'm going to break down treatment options in plain language and help you better understand what's ahead so that you can make confident, informed decisions. Hi, everyone. Welcome back to my channel. If you're new here, I'm Zacobia and I wear many hats, many titles, but what probably brought you to my channel in this video right now is the fact that I am a breast cancer survivor and I like to talk about and educate on things that a lot of people don't. And so welcome to my channel and let's dive in. So today we're talking about treatment options. And one of those treatment options that we'll start with is surgery. Surgery can have two different options as it pertains to breast cancer. And with those options, it can be a first line of treatment for some people, or it can be done on the back end. All right. So what we have is, we'll start with lumpectomy. Some women have the option of getting a lumpectomy. And whether you get a lumpectomy versus mastectomy really is based off of several different things. It has a lot to do with your particular cancer, your particular subtype, your particular grade and stage, and all those other things that we talked about in the previous video. And so based off of that information, then your doctor would recommend either a lumpectomy or a mastectomy. And so for some women, lumpectomy is an option. And what that means is basically the doctor is going to try to preserve the breast as much as possible. And so with that option, they're going to go in and target removing the tumor specifically and some of the breast tissue that is around that tumor and get what they call clear margins. They have a measurement of what they would like to see in terms of what that amount of tissue looks like. But for your purpose right now, just know that that means clear margins. When you hear them say we got clear margins, that means they were able to kind of get enough breast tissue to be confident that that tumor cell or, whatever characteristic of the tumor is not extended in that tissue that they're preserving. What you're going to be left with after they remove what they feel like is deemed necessary to remove, that's what we're going to consider a lumpectomy. And so with a lumpectomy, most women sometimes have to go in and get like a breast reduction on the other side to make it match. A lot of doctors, will do what they can cosmetically to try to make it look as normal as possible. But again, the goal with the lumpectomy is to preserve as much of the breast tissue as possible. The other option, like I said, is going to be a mastectomy. With a mastectomy, they're not preserving any of the breast tissue. They're trying to remove as much breast tissue as possible. And so with that, women who aren't candidates for lumpectomies, they're then recommended a mastectomy. And understand that, this is going to be your doctor's recommendation, but ultimately you get to decide like what you want to do. I don't necessarily recommend that you decide what you feel is best in those cases, because you're not the expert when it comes down to cancer and the subtype and all the characteristics of what you're dealing with. But again, I do want you to know that you have that option. If you are a little unsettled about what they're recommending, my recommendation for you would be to get a second opinion, third opinion, fourth opinion, whatever it takes to get you to better understand what it is that you're dealing with. But again, I want you to know that you have the option of not doing any of these surgery options. It is your body. It is your breast. It is your choice. Again, it's definitely not going to be the most popular opinion. It's not going to be the popular recommendation if that's what you decide to go with, but you do have that option. All right, getting back to mastectomy. With mastectomy, they're removing all of the breast tissue. Women who have that as the recommendation tend to have like maybe a very, very large tumor that they feel like they're not able to preserve much of the breast tissue, or it may be that they have multiple sites that they were able to pick up with MRI and additional testing that now show that, the breast the breast cancer is not just where you felt it or where the mammogram first detected it. It could be in other areas that's kind of scattered throughout the breast. And so anytime that it's kind of scattered like that, a lot of times they don't feel like they're able to preserve any breast tissue, and what you're left with is probably not going to be anything that is aesthetically appeasing anyway. And so that's usually when they recommend that you get a mastectomy and then, go through the reconstruction options that are available to you. So if you have like concerns about surgery as an option and what they're recommending, you want to know like what's the risk versus one or the other. Like if you're, on the side where you can get the lumpectomy or you can get the mastectomy, is really up to you. Because some women are, also have that as an option where they can kind of, choose what they want to go with. And that's usually based off of genetics at that point. Women who are BRCA positive may be great candidates for lumpectomies, but because you're BRCA positive, that puts you at an increased risk of recurrence, of dealing with breast cancer down, your lifespan in the years. And so some women, although they may be really great candidates for lumpectomies, the doctor may recommend the mastectomy just because you're BRCA positive. Or you may decide you want to get the mastectomy because you know that you're BRCA positive. And so with all of that, then this is things that you want to discuss with your breast surgeon to find out what's the best plan of action, what's the best surgery option that's available for you. And just to back up a little bit, like I like to point out the fact that, again, when it comes down to surgery, you have to consent to it. It's your choice. And I say that because I've heard people say like, well, they want to take my breasts. Trust me, doctors don't just want to take your breast. Like they have no reason to just want to take your breast. I know you feel real, good and confident about what you have and that somebody wants to take it, but trust me, they don't want to just take your breast. They're trying to save your life. And part of your life saving measure, part of extending your life well beyond, possible years of not doing anything, could involve, removing your breast. They don't want to take it. So we need to take that phrase out of our vocabulary. Like you find out you have breast cancer and your doctor is giving you what they believe to be the best treatment options, the best plan of treatment for you to extend your life well beyond, like I said, an individual who decides to do nothing. They're trying to save your life. Nobody's going in there trying to take your breasts. I know it's a male dominated field and it may seem like, yeah, they want my stuff. They have no reason to want your breasts. Okay. Well, the researchers may want your breasts. I will say that if you are going to elect to send that tissue to research, to send that breast to research, then yes, they want your breasts. But again, backing up, the breast surgeon is not in it just to take your breasts away. So stop saying that. So let's just make that clear. Research, yeah, they probably want it. Breast surgeons, they don't want the breast with the tumor in it. You shouldn't want it either, to be honest. I know people, like I said, decide that they don't want surgery, but I'm just going to be honest. You shouldn't want that breast if it got the cancer in it either. Okay, nobody should want the breast with the cancer in it. Just let it go. All right, let the researchers have it. Let them develop more treatment options and save more lives. We don't want that. Nobody wants that. Okay. All right. Another thing you may want to question is like, what does the recurrence rate look like if you did one versus the other? I know that with most oncologists, if you are a candidate for a lumpectomy, they may tell you that your recurrence risk is, the same whether you do the lumpectomy or the mastectomy. Now, me personally, I struggle with that because I feel like if you leave breast tissue there, then you still have the risk of recurrence. Anytime that there's breast tissue, and we know breast cancer starts in the breast tissue, then that puts you at risk for a recurrence. But that's not how science looks at it. That's not how oncologists and the researchers and all of them that have gathered all of this data to support, the recommendations kind of, explain it now. And so because of that, the risk may be the same whether you go with one or the other. Depending on your cancer type, subtype, and all the other information that comes with it and what they know about your particular diagnosis. Okay, the next treatment option that could be available to you is chemotherapy. And so chemotherapy, you may be wondering when, why, and under what circumstances do they make the decision whether or not a woman who's diagnosed with breast cancer needs chemotherapy. And I'm just going to be honest, it depends. Chemotherapy, it can be done on the front end before surgery, or it can be done on the back end after surgery. Some women need it, some women don't need it. And so it's not with a cancer diagnosis, it's not a one size fits all approach when it comes to treating women and saving lives. And so again, it depends. But with chemotherapy, I will say, like, chemotherapy today is probably not what you imagine it to be. It's probably not what you have had experience with or anything like that, because there has been so many advancements with it to make it more tolerable, to help people get through their treatment. Yes, it's probably still going to take your hair out. Yes, it's probably going to still make some people sick, but that's not a common thing across the board for everyone. I am one that can testify that when I was going through it, I didn't throw up one time on either side of the treatment with the chemotherapy options that I received. And, like I said, it depends. It depends. Everyone's different. But with chemotherapy, yes, it's probably still going to pull your hair out. There's probably going to be some side effects. They have things to help with the side effects, but there are probably going to be some side effects that you experience, unfortunately. Okay, because the chemotherapy is designed to target the cancer cells, but unfortunately, it can't target those cancer cells and not target the healthy cells. Like, they haven't gotten it, fine-tuned enough to where it can just target cancer cells and leave the good cells alone. And so unfortunately, because it, goes through and starts destroying every type of, cell that it sees, then that's when you start to see the side effects that we experience. And so, yeah, with that, chemotherapy is an option for a lot of people. There may be, your doctor may recommend that you take one chemotherapy drug, or they may be a recommendation of where you take a combination of medications. I took a combination. I had a phase A and a phase B, a part 1 and a part 2. And so it was a different cocktail of chemotherapy drugs that were designed to do different things. Chemotherapy can be designed to destroy the tumor. It can be designed to slow the growth, stop the growth. It can be designed to target a certain protein that's in that cancer cell. There's so many different types of chemotherapy drugs, and they all have a different, target, so to speak. And so with that, a doctor may put a combination of them together to make sure that we stop the growth and destroy the cells that are there. And so again, that is a conversation that you would have in this case, with your oncologist. That is going to be the person that decides the best course of treatment for you based off of what your subtype is, your grade is, your staging, and all of that. Like I said, some women don't need chemotherapy at all. A lot of times, if you have one particular subtype and you catch it early enough, then they can just give you a pill and you don't need anything else. But sometimes, with that particular subtype, if it has left the breast tissue and hit a lymph node or something like that, then it may change the course of treatment for that particular individual with that particular subtype. So going back to the previous video where we talked about subtype, we talked about grade and stage and all of that goes into this image that they are looking at when they're looking at how do we treat this particular person based off of what they have. That is what they use to decide those treatment options for you. So a special tip for you, if you find out that chemotherapy is a part of your treatment plan, you want to know how the plan is to approach it if you're not tolerating it. So with standard chemotherapy, the plan is going to be that you go through, several weeks and several cycles of this particular cocktail of chemotherapy drugs. And if everything goes well, they don't make any changes, no adjustments or anything like that. If they have you on a down dose or, a different plan, then it's because probably the standard is too much for you. And so know that that is an option. If standard is too much, it doesn't mean you have to come off completely. It just means that they may have to take the dose down. They may have to extend it out a little bit longer because they took it down now. And so those are conversations that you want to have with your doctor so that you know kind of what the plan is. So you're not sitting there miserable. That's the other thing. Doctors they want to help you. They want to fix you. They want to cure you, make you better. Because it helps them. Like, nobody wants to be a doctor that has zero success rate with their breast cancer patients. They want to win. They need to win. We need them to win. And so ultimately they want you to be able to get better, and they don't want you miserable and, just sitting there so sick that you end up in the hospital and you can't do anything. Like, that's not their goal. That is sometimes the outcome, but that is not their goal. They want to help you get better. And so we need to have these conversations with them so that they know that whatever it is that they're doing is either working, is not working, is working too good, and we might need to make some adjustments to it. All right. So be upfront and have those conversations with them. The other thing that you want to do is make sure that, you understand everything that it is about those particular drugs that you are receiving. You want to know what are the side effects based off of that one, because no two chemotherapy medications are the same. This one might have that side effect. This one might have that side effect. And if you're doing a combination of them, you want to know what it is that you're taking. So ask questions, know what you're taking, how often you're taking it, and what you can expect from it. Another treatment option is radiation therapy. And radiation therapy is more targeted therapy. So you don't tend to have as many side effects as one would have if they had the chemotherapy. Because again, it's more targeted and localized to the particular area that has the cancer. And so it's designed to target those specific cancer cells that are maybe microscopic that we don't see on imaging anymore. But because you chose to go with a lumpectomy, or it was, recommended that you go with a lumpectomy, they want to be careful to make sure there are not any microscopic cells that we can't see that may, wake up and decide to do something, to cause problems later on. And so that's what radiation therapy is designed to target, those cells that nobody can see, that nobody even knows that they possibly exist yet. Radiation is usually always given if someone is a candidate for lumpectomy. Usually, I can't say all the time because I'm not a radiation oncologist, but based off of from what I learned and the experience that I have now in the breast cancer world, most women who get a lumpectomy are also recommended that they get radiation therapy as well. Sometimes with mastectomy patients, it's recommended that they get radiation as well. So just because you got the mastectomy doesn't automatically mean that you don't need the radiation as well. With mastectomy patients, it usually comes down to whether or not there was any lymph node involvement that determines whether or not the radiation is needed for those particular patients. So again, lumpectomy, almost always definitely going to get radiation. Mastectomy, it's a question mark, and it's usually dependent upon whether or not the cancer went to a lymph node, or, something like that. Outside of that, again, either one could be recommended to get it, but it's usually coupled together with lumpectomy. The schedule is from what I hear is doable. I didn't have radiation, so I don't have personal experience with it. But for those who have, everyone says that it's doable, and it's definitely much doable than chemotherapy because you don't get all the major side effects with the radiation therapy. With the radiation therapy, the most common side effects are going to be like burns at the site. And also just like, feeling fatigue because of the radiation treatment. It tends to make you more tired and, drain your energy a little bit more. So those are the most common side effects. Can't say that there's no other side effects. Again, I didn't personally have it, but those are the ones that are most common. But again, for most people, they're able to carry on with their day-to-day activities and go on with their life when they're going through radiation, because that treatment process is so quick. Usually it's done 5 days a week, but you're going in there for maybe 15 minutes instead of 5 hours. When I would go for chemotherapy, I would be there for hours at a time. With the radiation therapy, you're going in, getting undressed, getting on the machine, get a few minutes of the radiation, targeted treatment, and then boom, you're dressed, you're done, and you're going on back, throughout, going on back about your business, going on back, throughout the day. And so with that, most people are still able to, like I said, maintain a normal active life, because it's usually a small percentage of time that's taken out of their day to go get the radiation therapy. And it's over, a few weeks and not a few months. So again, it's usually 5 days a week, and you're probably doing that for 4 weeks, 5 weeks, something like that, as opposed to months at a time and hours at a time. And so, you want to talk to the radiation oncologist to make sure that you have what's necessary if you do have to get it. Like, you want to be prepared if you do get the really bad burns, because I do hear that they can be uncomfortable. And you want to know, again, like, what does that schedule look like for you? And, just have a really good understanding of whether or not, you are going to be recommended for it. And if so, why are you recommended for it? Make sure you have a good understanding of why you're getting it, and, ask all the questions that you may have. Okay, next up, there's going to be hormone blocking therapy. I think I said replacement early in the video. If I did, please excuse that. It's not hormone replacement, it's hormone blocking therapy. And so hormone blocking therapy is usually going to be for women who have a ER or PR positive type breast cancer. So again, it's important that we know the subtypes, because that all goes into play in terms of your treatment options. So if you are ER or PR positive, then your doctors are going to want to block those hormones, because it is those hormones that is feeding your cancer and causing those cancer cells to grow. And so they're going to want to block those. And so typically that's done with taking a pill. With those that are ER and PR positive, a lot of times they don't even have to go through the chemotherapy if it's caught early enough. For those who, maybe they didn't catch it as early enough, but they're still not terminal, sometimes they go through chemotherapy and they still have to take a hormone blocking therapy for a couple years. And so those years usually look like about 5 to 10 years at a time, based off of, again, your particular subtype, your diagnosis. But I do appreciate the fact that those who have ER and PR positive cancers, like I said, when they're caught early, a lot of times they don't have to go through, the necessary steps of going through chemotherapy, because of the advancements we've had in medicine to bring forth a pill that you can take for a couple years to suppress those hormones and stop, feeding that tumor. And so, yes, they may still get a lumpectomy. Yes, they may still get a mastectomy. But now, we have this additional therapy that can be taken to help reduce the risk of a recurrence later down the line. So if you have to do a hormone blocking therapy for a couple years, you want to know the specifics with it, because, not everything is going to be free of any type of side effects. And so you want to know what it is that you may have to deal with, whether it's hot flashes, mood changes, because again, it's blocking those hormones. And so if it's blocking hormones, then how does that ultimately affect you and your body? And so be sure to ask those questions, because I don't know personally in terms of like how bad it may be, but just based off of, knowing, several individuals that have had to take it for years and years at a time, it does affect your, normal life a little bit. And so those are either adjustments that you have to like basically settle on for a couple years, or again, everything is a choice. You can make the choice that, I'm not going to do this for this long. I'm going to do it for this year. Can we try this option? You basically have to advocate for yourself and make the best decision for you and your quality of life. The other treatment options can be targeted treatment or immunotherapy, or immunotherapy. And so if you have the HER2 positive receptor, then you would be a candidate for targeted treatment with a medication called Herceptin. And so with Herceptin, it's targeted to just affect that particular cancer and not necessarily affect, everything or every cell that's within your body. It's targeted, hence the name. Not to say that it's going to be, free of any side effects or anything like that, because there are side effects with that as well. Yet it's not going to be the same side effects as you would possibly go through if it was chemotherapy, because chemotherapy, like I said, affects all the healthy cells too. So it causes hair loss and all of that. Whereas the Herceptin doesn't cause, your hair to fall out and things like that. And so you want to know, what it is that you can expect for that particular treatment plan. With immunotherapy, those are usually options for those that deal with a triple negative breast cancer, like in my case. And so I did have personal experience with immunotherapy. The drug for me at that time was the Keytruda. There are other immunotherapy drugs out, as of this date of recording, but that is the particular med that I received. And again, like with everything that I've said so far, it had its side effects as well, but the side effects that I had, it wasn't to the point of which I wanted to not take it because they were so bad. The side effects that I dealt with were more skin related. So thankfully I had a, dermatologist that could help prescribe certain medications to just basically help get me through until I was done and off of the immunotherapy. But I'm grateful that the immunotherapy was an option for me as a person that was diagnosed with triple negative breast cancer, because that is the particular one that doesn't have the hormone blocking or the targeted treatments. And so, you feel a little special knowing that there is something out there that can help with your particular diagnosis. And so, questions to ask is, what are your biomarkers? You want to know whether or not you are a candidate for immunotherapy and targeted therapies. Again, chemotherapy, and, that's usually not always the first line of treatment for everyone. And so knowing your subtype, knowing your staging, knowing your grade, and all of that is going to be important, and knowing more about what options are available to you with dealing with your particular type of the breast cancer. And so I know I just talked about a lot of treatment options. And so you're probably still kind of wondering, well, how is all of this decided? And so just to kind of tie this back in again, it's decided based off of your particular diagnosis, your staging, your subtype, your grade, and all of that information that they gather up front, just so that they know everything that they need to know about what it is that you're dealing with. Other factors that go into it is your age as well. And so a woman that is younger, that is diagnosed with breast cancer, may get a more aggressive plan of treatment. It may seem like, man, gosh, you had it all. And that's usually because she's younger, and because she's dealing with it younger, and maybe, a wife, a mom, or wants to start a family one day, that doctors again are trying to save her life. They're trying to extend this life as far out as possible. And so it could mean that treatment plan for her is more aggressive. Whereas if a woman is diagnosed in her, 80s, they may not even recommend chemotherapy, because you've already lived such a long life at that point. And the side effects of the chemotherapy could be that, whatever time you have left is miserable. And doctors are just like, we just don't think it's necessary to make, whatever this time is miserable. And so a lot of times that treatment may not be as aggressive. Doesn't mean that they're not going to treat, that individual. However, it may not be as aggressive, because an aggressive treatment on a older individual could decrease their quality of life tremendously. And so, they look at all of that when they're, looking at, this particular patient and what it is that they're dealing with. They're not just, again, it's not a one size fits all approach. It's a lot of things that go into it that help them determine what they feel like is the best option for this particular person. And, a lot of doctors don't even make this decision by themselves nowadays. Now there's a team in place, and they consult with other doctors, because again, ultimately everybody wants a win. Like every time we save a life, and that woman is able to now go out and advocate and testify and all of this good stuff, then we can save much more lives behind that. And so everybody wants a win. I want to win. I know my doctor wanted to win. And so, that's important in your team as well. And so being a part of a team where, we all want to be winners is absolutely amazing. And so knowing that everybody wants to win can maybe help you process what it is that they're recommending a lot differently, when you know that they're just not doing it just to do it. Like, they're doing it to help you get better, to help you overcome this health crisis, and put it behind you and go live a long, beautiful life. That is the goal for everyone. That should be the goal for everyone. And so again, there's no one size fits all. There's all these different characteristics that go into it. And again, age and all of that even goes into it as well. So again, I know that this was a lot of information, but I hope that this has provided some type of clarity in this storm that you're facing, in this journey that you now have to, take as it pertains to your life and your future. I know it's a lot, but I think it's good to have a lot of options. There was a time where it was only surgery that was an option. And so, to now know that we have all these other options is absolutely amazing. And it's just a matter of being informed of what options are and what's best for us. And so if you have, found this to be helpful and you think that it's helpful for someone else, don't gatekeep this information. Please share this information and help someone else. All right, guys. So thank you so much for watching. Like, comment, share, and there will be another video coming out very soon. I apologize for the delay in this one because I'm usually trying to hit it every week, but I didn't announce this in the beginning, but I just sent my son off to college. And so his schedule kind of threw me off a little bit with, dropping him off last weekend and getting him prepared and moved in and settled and all the things that, we are finding out that he needs to be successful in college. It kind of caused me to slow down a little bit. And so I apologize for the delay in getting this video out. But with my next video, we're going to talk about how to manage side effects. I talked about a lot of those side effects that you may see in today's video, and we're going to talk about how to manage some of those side effects in the next video. So make sure you subscribe, make sure you turn on your notifications so you don't miss it. All right, until next time, peace.